Hello everyone and welcome to Chapter 28 in MedSurg 1. This is caring for clients with heart failure. The learning objectives for the chapter are as follows. You should be able to discuss the pathophysiology and etiology of heart failure, distinguish between acute and chronic heart failure, identify the differences between left-sided and right-sided heart failure, describe the symptoms, diagnosis, and treatments of left-sided and right-sided heart failure. You should also be able to discuss the medical and nursing management of clients with heart failure, as well as discuss the pathophysiology, etiology, symptoms, diagnosis, and treatments of pulmonary edema. Also, review and discuss the medical and nursing management of clients with pulmonary edema. Here are the medical terminology terms that you need to know for this chapter. So here's a review of cardiac function. Remember, the heart is a double pump. The right side pumps deoxygenated blood to the lungs for oxygenation, while the left side pumps oxygen-rich blood into the systemic circulation. This process provides a continuous supply of oxygen and nutrients, cellular metabolism, and the mechanism to eliminate carbon dioxide. Disturbances in one part of the heart, if severe or prolonged, eventually affect the entire circulation. Now, heart failure is the inability of the heart to pump sufficient blood to meet the body's metabolic needs. The ejection fraction estimates the heart's efficiency. Now, normally the heart ejects 55% or more of the blood that fills the left ventricle during diastole. Congestive heart failure, also known as CHF, is the accumulation of blood and fluid in organs and tissue from impaired circulation. Now, heart failure ultimately affects oxygen transport to the brain. So that's why it's often important to determine or assess your client's level of consciousness whenever they are experiencing heart failure. So we have acute heart failure and chronic heart failure. Acute heart failure is sudden. It's a sudden change in the heart's ability to contract, and this causes life-threatening symptoms and pulmonary edema. While chronic heart failure is gradual, meaning that the heart's ability to pump effectively is gradually compromised. So this impaired contractility can remain prolonged, meaning that the client can have chronic heart failure. We clear that up with some diuretics. They go home. They come back 3 weeks later or a month later, and they're in heart failure again. So it can continue to happen over a period of time because of that impairment. A low EF, a low ejection fraction, is a hallmark of a heart failure. So you're going to see that when they do that echocardiogram, you're going to note that EF. And if it's less than 55%, that's where you're going to have that heart failure diagnosis come into play. Now, hypertension, tachydysrhythmias, valvular disease, cardiomyopathy, and renal failure can contribute to chronic heart failure. So these are conditions that can cause a client to have chronic heart failure: hypertension, tachydysrhythmias, valvular disease, cardiomyopathy, and renal failure. So here's kind of a side-by-side comparison of stages and classes of how heart failure is ranked or diagnosed. So you have stage A through D, so you have a high risk, and that goes down to your end stage for your heart failure. And then as far as your classes go, you have a class 1, which is your mild, and then that goes up to your class 4, which is your more severe. So heart failure is the inability of the heart muscle to contract, and usually that's from direct damage to the muscular wall. You have a low output failure, that is your left-sided heart failure and your right-sided heart failure, and these are the conditions that we're going to talk mostly about. So your left-sided heart failure is caused by MI, cardiomyopathy, hypertension, CAD, and angina, while your right-sided heart failure is caused by, yes, left-sided heart failure that progresses, right ventricular MI, pulmonary problems such as COPD and pulmonary fibrosis. So now there is a compensatory mechanism that takes place during heart failure. So you have a reduced cardiac output, and you see that with hypotension. That hypotension stimulates the sympathetic nervous system to release catecholamines, and that's to increase the heart rate and the blood pressure, so the body's trying to compensate. So along with that, you have increased force and contraction of the heart to maintain blood pressure, and so that increases myocardial demand. Epinephrine causes the blood vessels to constrict, and the body shunts more blood to vital organs of the brain and the heart, decreasing supply to the kidneys. Then the ventricles of the heart secrete neurohormone B-type nutrienic peptide, also known as BNP. Now you need to know the BNP levels. This is a box that came out of your textbook. So BNP of less than 100 indicates no heart failure. 100 to 300 suggests the presence. Greater than 300 to 599 is mild. 600 to 899 is moderate. And greater than or equal to 900 is going to be severe. So now we're going to first discuss left-sided heart failure. With left-sided heart failure, the left ventricle fails the heart, meaning that the muscle cannot contract forcibly enough to expel blood into the systemic circulation. So with this, you have an accumulation of fluid, and that creates the congestion of the pulmonary vascular bed. Your gas exchange is impaired as well, so the cells become hypoxic, meaning that the CO2 accumulates in the blood. Hypertension, tachydysrhythmias, valvular disease, cardiomyopathy, renal failure can contribute to chronic heart failure, which is oftentimes associated with left-sided heart failure. You have a reduced ventricular ejection volume as a result of this condition. The ventricle is not able to contract effectively to force out that blood or volume, so you have an excess. So this is just a picture to kind of refresh your memory about preload and afterload. So you must know all of the assessment findings associated with left heart failure. You have hypoxemia, unusual fatigue with activity, exertional dyspnea. This is usually the very first symptom the patient will complain about. Orthopnea, nocturnal dyspnea. So the patient has to sleep on several pillows. They may have to sit up in a chair to sleep. The pulse may be rapid or irregular. Atrial fib is oftentimes associated with heart failure. They have a displaced apical pulse. They have an S3 heart sound. The blood pressure is elevated. They have a cough. They have hemoptysis with frothy sputum, moist or fine crackles. The urine output is diminished. It can progress into pulmonary edema. The patient can become hypoxic. They become restless and even confused. That's why it's important to assess the client's level of consciousness when they have heart failure, experiencing heart failure. So for the visual learners out there, this is a nice little cartoon that just shows the assessment findings of left-sided heart failure. So to diagnose left-sided heart failure, we're going to do a chest x-ray because we're going to be looking at cardiac enlargement and fluid accumulation in the lungs. We're going to do an echocardiogram. That's going to show the size of the left ventricle and the ineffectiveness pumping of the heart, like your EF. We can do a MUGA scan, arterial blood gases. We can insert a pulmonary arterial catheter. We're going to draw some lab work. We're going to draw a BNP. We're going to look at the electrolytes as well as cardiac enzymes. They may even want to do a TEE. Remember, that is your transesophageal echocardiogram. And they may want to do an ultrasound of the left ventricle as well. So now let's move into right-sided heart failure. So right heart failure is when the right ventricle cannot forcibly contract and push the blood into the pulmonary artery. This is associated most often with chronic respiratory disorders. Congestion of blood and backflow accumulates first in the right ventricle, then in the right atrium, then the superior and inferior vena cavas as well. Now, cor pulmonale is a condition in which the heart core is affected secondary by a lung damage, which is your pulmonale. You must know all of the assessment findings of right-sided heart failure. These clients have a gradual, unexplained weight gain. The client may complain of tightness of their rings, shoes, or clothing. You also have ascending dependent pitting edema. You'll see this in their legs and ankles. Dependent edema is excess fluid volume in the interstitial space in the body, and it's usually affected by gravity. That's why you see it in the feet and ankles. But know that it may disappear in those regions overnight. So you may find that dependent edema in the sacral area. The client will also have ascites, abdominal distension, hepatomegaly with tenderness, JVD, which is your jugular vein distension, nausea, anorexia, fatigue, weakness, and polyuria. Once again, for the visual learners out there, here's a cartoon for your right-sided heart failure assessment findings. So many of the diagnostics we use for left-sided heart failure, you're going to also use for right-sided heart failure. Chest x-ray, echocardiogram, lung scans because you're looking at pulmonary involvement if there's an underlying pulmonary disorder, liver enzymes because of the hepatomegaly, cardiac enzymes, electrolytes, ABGs, ultrasounds of the right ventricle, TEE, and BNP. And this is just another cartoon with a side-by-side comparison of left-sided and right-sided heart failure signs and symptoms. So, medical management of heart failure, whether it's left or right, is essentially the same. Of course, we're going to start with those dietary modifications. Our direct therapy may consist of digoxin. We may give some diuretics such as Lasix, which is also known as furosemide. This is a loop diuretic which can lower the potassium levels. So we need to monitor that potassium level whenever we're given Lasix because we need that potassium to help with that electrical current that the heart needs to contract, correct? We may give some vasodilators. ACE inhibitors such as captopril may also be given. Some clients may have a cardiac resynchronization done as well as an intra-aortic balloon pump. Now, if you're going to give a diuretic as a nurse, how do you evaluate the effectiveness of a diuretic? And know that if your client is experiencing an acute episode and they're in some acute distress from their heart failure, that you have got to get them that IV diuretic as soon as possible. They need that IV diuretic first before anything else because they have to get rid of the excess fluid in order for them to breathe effectively. Some clients have such severe heart failure that they require surgical treatment, such as a ventricular assisted device. They also may need some ventricle restoration, and some may even need a total heart. They may get a artificial heart in the meantime, but some people need a complete heart transplant because of their heart failure. So as nurses, we have to do a lot of teaching, lifestyle changes, dietary restrictions. When the client's in the hospital, you need to make sure that you administer those medications and monitor for therapeutic and adverse effects. You need to monitor for signs of excess fluid volume, evidence of electrolyte imbalances. Like I said, if you give that IV Lasix, you need to monitor that potassium level. You need to promote oxygenation. They need to have a really good balance between activity and rest and give some support to those family members who may be there as well. So you make sure that you are documenting effectively, document those assessment findings as well as the client's complaints and response to interventions. Check that weight at the same time every day using the same scale. Consult the doctor if there's an increase in the weight gain, and that's going to be part of your discharge planning as well. So when the client's discharged, you need to tell them to weigh themselves every day at the same time. You need to instruct the client to notify the healthcare provider if they have more than 2 pounds of weight gain in 24 hours. And know that weight is a good indicator of a client's status, meaning how effective their treatment's going. Be mindful of giving medications to our older population because they are more susceptible to developing toxicities from one or more of the medications that we give. So be mindful of that older population and giving them those medications. So now we're going to move into and discuss some flash pulmonary edema, which is a medical emergency, and this is a complication of heart failure. Pulmonary edema is when the left ventricle is incapable of maintaining sufficient blood output because the blood volume and pressure builds up in the left atrium. So you have fluid accumulation in the lungs, which interferes with gas exchange in the alveoli. Acute pulmonary edema is a life-threatening emergency. It can even lead to cardiogenic shock. And this is common following an MI, when there is an injury of 40% or more of the ventricle. It can also lead to pericardial tamponade, which is a fluid accumulation in the pericardial sac. You can have non-cardiac pulmonary edema, and this is when you have inhalation of some irritating gases or rapid administration of IV fluids can occur. You can have acute respiratory distress syndrome can occur from that as well. So say you had a client who was getting IV fluids and they were DC'd, but they never got taken down. They continued to infuse. That patient can accumulate so much fluid because of that it can throw them into respiratory distress. You can also have neurogenic pulmonary edema, and this is whenever there is some type of brain or head injury, a neuro event has taken place. That type of head injury has caused that non-cardiac pulmonary edema. You must know the signs and assessment findings of pulmonary edema. This is sudden dyspnea, wheezing, orthopnea, restlessness, cough with productive pink frothy sputum, cyanosis, tachycardia, severe apprehension, respiration sounds moist or gurgling, hypotensive, peripheral pulses disappear. Complications from pulmonary edema can be dysrhythmias, respiratory arrest, cardiac arrest. You need to activate the emergency response system and remember CPR. Pulmonary edema is the accumulation of fluid in the lungs, which interferes with gas exchange in the alveoli. It represents an acute emergency and is a frequent complication of left-sided heart failure. Cardiac dysrhythmias and cardiac and respiratory arrest are associated complications. So remember, pulmonary edema can be fatal and it is very life-threatening. We diagnose pulmonary edema with a chest x-ray because we're looking at those pulmonary infiltrations of fluid. We do an ABG. We're looking for hypoxemia as well as hypercapnia, and we're looking for a pH of below 7.35. These are ABG or arterial blood gas normal value ranges. pH 7.35 to 7.45, PaO2 75 to 100, PaCO2 35 to 45, bicarb, which is your HCO3, is 22 to 26, and you should have an oxygen saturation 94 to 100%. So a client's respiratory status is severely compromised during pulmonary edema. They develop respiratory failure quickly. When respiratory failure occurs, the client lots of times has to be intubated. Oxygen is administered under continuous positive pressure, meaning we put them on a mechanical ventilator for that reason. So we want to make sure that we have that type of emergency equipment readily available for those clients experiencing pulmonary edema because, like I said, it is life-threatening. So the medical management for pulmonary edema, of course, is supplemental oxygen, but oftentimes that's not enough. We have to intubate and mechanically ventilate the client. We're going to use some drug therapies such as dobutamine, dopamine, digoxin, diuretics such as your Lasix, nitrates, your ACE inhibitors, and calcium channel blockers. We may even give some morphine. Now, morphine helps relieve those respiratory symptoms by depressing the higher cerebral centers of the brain, and that relieves the anxiety that the client's feeling. It actually slows down their respiratory rate and promotes muscle relaxation and reduces the workload of breathing. So the patient doesn't have to work as hard because they're relaxed. As nurses taking care of someone with pulmonary edema, we have to get that IV line in immediately so we can give medications. We're going to monitor the ECG. We're going to monitor the pulse ox. We're going to get that automatic blood pressure going. We're going to probably take that blood pressure every 10 to 15 minutes. We're going to put in a Foley catheter most of the time so that we can get an accurate output, and because the patient is so short of breath during an episode of pulmonary edema that they cannot tolerate being rolled to be placed on a bedpan, nor can they walk to the bathroom. So oftentimes we'll put in a Foley to measure that urinary output. Oxygenation, of course, we're going to give them that supplemental oxygen, but we're also going to know that we may possibly have to intubate that patient. Frequent mouth care, because lots of times they're breathing so difficult and they're having such a hard time that they're breathing through their mouth rather than their nose. They're gasping for that air. So you may want to swab that mouth frequently. Make sure you have adequate suction available. And always stay with the patient. Never leave your patient that is having an episode of pulmonary edema. It is very, like I said, life-threatening. Those clients have impending doom feelings. They feel that they're going to die, so you do not ever leave that patient alone. You call and get some help, and either they stay with the patient or you stay with the patient. Never give up, because great things take time. And you all are going to be great nurses. It's going to just take some time. Never give up.